Hi friends, I am Dr. B.V. Rao of Usha Clinic and founder of the websites qmedicaldoubts.blogspot.com and raghavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary. For the medical knowledge to general people and for reference to medicos. Today I am going to discuss about the endometriosis, types, diagnosis and treatment. Endometriosis is the presence of ectopic endometrium in any situation outside the normal location. The criteria to be present are an appearance of the epithelium resembles that of endometrium, the presence of endometrial stroma surrounding the glandular spaces. The endometrium should be responsible to the endocrine stimulus of estrogen and to a lesser degree of progesterone. Sawtooth-like crenated appearance of progestational stage of cycle. The content of the ectopic endometrial glands is dark tarry menstrual blood. The presence of pigment-laden pseudoxanthoma cells or large polyhedral contain hemosiderin. It is common in 30 to 40 years of nulliparous women. Types: internal endometriosis or adenomyosis. The islets of endometriosis penetrate from the basal layer of endometrium into the myometrium. Endometriosis externa. Endometriosis externa is the ovary endometriosis of the pelvic peritoneum involving ovary and rectosigmoid. Distant extrapelvic endometriosis in scars, peritoneal hernial sacs, umbilicus, appendix, perineum, arms, legs and pleura. Etiology. The implantation theory, Sampson explained the chocolate cysts and pelvic endometriosis. Serosal theory explains it is due to metaplasia of the peritoneal mesothelium. Hormonal influence. Its development depends on the presence of the active circulating ovarian hormone. Adenomyosis externa. Clinical features. Menorrhagia of severe degree. Infertility is a common symptom. Congestive dysmenorrhea is present. Weight in the pelvis. Enlarged uterus of about 3 months pregnancy and is painful. Treatment. Hysterectomy is the correct treatment because about 40 years of age, possibility of conception is rare. It is impossible to excise the tumor and conserve the healthy uterus. If the ovaries are healthy, they need not be removed. If the adenomyosis is localized and confined to one corner of uterus, the patient is young and anxious to have child. Localized excision is feasible. After explaining her about its recurrence after some time. Endometriosis externa. Though there are many types, they frequently coexist in all organs. Though one organ may be involved. Chocolate cyst of the ovary. It is usually bilateral, measuring about 2 inches in diameter, rarely maybe up to 7 inches in diameter. The ovary is enlarged, outer surface is white and thickened. Ovary and fallopian tube are prolapsed and fixed to the back of the uterus, broad ligament and sigmoid colon, and pelvic endometriosis. It is not possible to separate the ovary from the attachments. Pelvic endometriosis. A minor degree of pelvic endometriosis is extremely common. Symptoms of ovarian and pelvic endometriosis, usually identified during the hysterectomy. Pain, dull, aching pain in the mid-pelvic region and referred to sacrum, lumbar region, rectum and lower abdomen. When chocolate cyst ruptures, a leak or leaks, a severe pain like appendicitis pain may be present. Dysmenorrhea. Congestive dysmenorrhea of sudden origin is suggested. Disturbance of menstruation. Menorrhagia with short cycle is common. Dyspareunia. If involves the uterosacral ligament, rectovaginal septum or retroversion of uterus. Infertility. The commonest symptom of endometriosis is the infertility. Bowel symptoms. Constipation or difficulty in defecation may occur. Diarrhea, tenesmus and subacute intestinal obstruction may be there. Gallbladder symptoms. It is rare but when occur may cause hematuria or periodic urinary infections. Endometriosis of rectovaginal septum. The proliferation may spread down along the rectovaginal septum or backwards to infiltrate the wall of the rectum. Symptoms: painful defecation, etc. Physical signs: if bimanual examination reveals fixed bilateral appendage swelling, fixed tender retroversion of the uterus with pain, it is a confirmed diagnosis. Differential diagnosis: chronic salpingitis or salpingo-ophoritis, multiple small myomata, ovarian cancer, carcinoma of colon, ruptured tubal pregnancy. Treatment: it depends upon the age of the patient and severity of the symptoms. At laparotomy, healthy ovarian tissue can be salvaged in one or both ovaries, and ovarian cystectomy should be performed. Mostly it may be inevitable to have a total hysterectomy. After surgery, other areas of endometriosis are found and may be treated by fulguration. Removal of ovary will regress the remaining foci. Care must be taken to save the large and small bowel while dissecting the adhesion. Followed by hormone therapy. Synthetic progestational steroid, norethindrel, dose increasing up to 40 milligrams for 6 months to 2 years with good results. Some may not prefer it due to side effects of the drug. Then it stands as a measure of diagnosis by therapeutic test. Cyclical hormone therapy with norethindrel or norethindrone has become popular at a dose of 5 milligrams given daily for 5th to 26th day after removal of surgical removal of majority of the disease. This dose may be tried from 15th day to 26th day. This suppresses endometriosis and does not suppress ovulation. Estrogen should never be given after surgery or radiation, or disease may be reactivated. That's all about the endometriosis, and in the next video I will discuss about some other disease. Thank you.